All right, good. Okay, so this is a parasternal long axis view, and this view is obtained by putting the transducer, the probe, in this third or fourth left intercostal space with the marker pointing towards the right shoulder. And the structures you're going to see is this is the septum, okay, LV cavity, posterior wall. This is your mitral valve is right here. The anterior leaflet is on top. Posterior leaflet is right there. This is the left atrium, okay. Your descending aorta is right there. Aortic valve is right there. The ascending aorta, and this is your right ventricle. So put it in motion. You can see the aortic valve opening and closing, the mitral valve opening and closing. In systole, the muscle thickens, and in diastole, it thins. So this is what your parasternal. So we do Doppler for, all of these different images. We do Doppler because the Doppler allow you to pick up if there's any regurgitation, if there's any abnormal flow, shunts. So this is the color flow. So you got to put color flow across the valves because you want to see if there's any regurgitation, any leaks. So it's across the aortic valve, then you're going to put it across the mitral valve, and then, when you have appropriate views, you put it across the tricuspid valve and the pulmonic valve. So you have to do that. So we do color flow. Color flow is going to give you a quick qualitative assessment if there's any regurgitation or any abnormal flow. Then once you locate that, then you can do quantitative assessment. So we put our color flow across the aortic valve, and we put it across the mitral valve. Remember, the color is coded, and flow towards the transducer is going to be shades of red, and flow away from the transducer shades of blue. So similarly, we'll put it across the mitral valve. Okay. So again, you must always locate your transducer. Transducer is right there. Okay, so on a long axis, you should be able to identify all the structures on a long axis. Okay, so you can zoom, if you want to have a closer look at any structures, you can zoom it. Okay, so again, this is the RV inflow view. Right ventricle is on top, your tricuspid valve. This is the posterior leaflet, the anterior leaflet. This is the right atrium. Okay, coronary sinus is right there. Inferior vena cava is right there. So the RV inflow view. Okay, so again, we'll put color across all of our valves. So we'll put color across the tricuspid. I will play it. If you look closely, there is a mosaic jet right here. It's it's a mixture of colors, but probably more blue than anything else. See it right here. So let's look at it closely right there. So this is tricuspid regurgitation. It is varying shades of blue, because remember your transducer is right there. With tricuspid regurgitation, blood is flowing from the RV across the tricuspid valve into the right atrium. It's a turbulent flow, so you're going to get a mosaic color. So you can see the mosaic color right there. So qualitatively, this is your tricuspid regurgitation. Flow from the RV across the tricuspid valve into the right atrium, tricuspid regurgitation. Okay, so that's what TR looks like. But so we have to wait on that. So the next set of image is going to be your pulse wave. Remember that color flow Doppler is a type of pulse wave Doppler, but it's color coded. So it's color coded. So we just have to wait until. Well, I guess this is still color. This is a still of color, but that's okay. So remember that your pulse wave Doppler is going to measure low velocity flow, 1.5 to 2 meters per second. Okay. All right. So the two-dimensional image is on top. Your cursor is across the tricuspid valve. This is the sample volume. The sample volume is right there, and you press P Doppler. Of course, your ECG, and you see a hint of a flow right there, or there's an envelope right there, envelope there. Okay, sorry, not there, but there, there. So this is the tricuspid regurgitation in color, varying shades of blue, and it's blue because again your transducer is right there. The flow is from the RV, right ventricle, across the tricuspid valve into the right atrium. So it's moving away from the transducer. So it's going to be varying shades of blue, but somewhat a mosaic. It's not a lot of tricuspid regurgitation, so the corresponding Doppler is not significant. It doesn't look significant. What we're going to do, we're going to go over a number of studies so you get an idea what tricuspid regurgitation, mitral regurgitation, aortic insufficiency, pulmonic insufficiency looks like. So this is, this is a little envelope. I mean, you probably doesn't recognize this little envelope, and it's a systolic flow from the onset of the QRS to the end of the T wave, but because it's not significant, you don't get a complete envelope. But as you can see, when we do our studies, the studies are loaded with Doppler. So again, the short axis at the level of the aorta. So you're going to rotate your transducer from the area that you got your parasternal long axis. You're going to do a clockwise rotation, 1 or 2 o'clock position. You're going to pull the angle of the transducer downwards, and you're going to get, this is the aorta with the aortic valve in place. Pulmonic valve is right there, pulmonary trunk, and it's going to split to give you a right and a left. And then this is the RV. This is a tricuspid valve right there, the right atrium, and the atrial septum is right there, so we can play. So again, remember, if this is your atrial septum, the coronary cusp that is adjacent is the non-coronary cusp. Then the right will be there and the left will be there. So you need to know the structures that you're looking at. It's very important. So they tend to do a lot of still images. Okay, so we'll put color. So we'll put color across the aortic valve to see if there's any regurgitation, and that has a distinct visual. And then we'll put it across the pulmonic valve, and we'll put the color across the tricuspid valve. So you should put your Doppler across all the valves because you want to see if there's any regurgitation. Okay. Okay, short axis at the level of the aorta. You can see that there are 3 leaflets or 3 cusps. You can see the pulmonary valve open and closing, tricuspid valve opening and closing. Okay, so one of the things that you need to do is to establish that there are 3 cusps across the aortic valve, or 3 leaflets. It's very important because if the patient have bicuspid aortic valve, then they're going to run into problems sooner or later. Okay, so you put your color across the pulmonic valve, color across the pulmonic valve. We're looking for pulmonic insufficiency. If you look closely, there's a little red jet right here. Or you see, look closely, there's a little red jet. Okay. So again, your transducer is right there. This little red jet that you see, it's because there's a flow from the pulmonary trunk across the pulmonic valve into the right ventricular outflow tract, or the right ventricle, and that's pulmonic insufficiency. It's moving towards the transducer, and it's red. See, it's a little jet right there. See, so that's pulmonic insufficiency. So you have to look for it, and it's red because it's pulmonic insufficiency. Pulmonic insufficiency says blood flow from the from the pulmonary trunk across the pulmonary valve into the right ventricle. Okay. So you use your color to assess qualitatively, and then you can quantitatively do additional Doppler assessment. Okay, so this is the little jet that we're talking about. This little jet, and it's varying shades of red because it's a flow going from the pulmonary trunk across the pulmonary valve into the right ventricle. So it's moving towards the transducer. Transducer is right there. So you have seen it with color flow Doppler. Now you can put a pulse wave Doppler and have a better look. Okay. Now this is your ECG, and if you look closely, you get there's a flow right here, there's a flow right there, there's a flow right there, flow right there, flow right there, and this flow corresponds. So this flow corresponds to pulmonic insufficiency. Again, it's a flow from the pulmonary trunk across the pulmonary valve into the right ventricle. So it's moving towards the transducer. So it's going to give you an envelope above the baseline. So you're going to get an envelope above the baseline. So pulmonic insufficiency is a diastolic flow from the end of the T wave to the QRS. So it's a diastolic flow which is above the baseline. And that is because the flow is moving towards the transducer. Okay? Okay. So you put your cursor across the pulmonary valve. The sample volume is right there, and you press PW. So this is a PW assessment, and you get an envelope like this, another envelope, spectral envelope that is. You can see, okay? And when you look at your ECG, you see that the envelope occurs in systole from the onset of the QRS to the end of the T wave. So you get a systolic flow, which is below the baseline. Systolic flow below the baseline. So that's telling you that the flow is moving away from the transducer. So the flow is moving away from the transducer. So the flow is moving from the right ventricle outflow tract across the pulmonary valve and into the pulmonary trunk. The flow is moving away from the transducer, hence it's below the baseline. So it's moving from the right ventricle outflow tract across the pulmonary valve into the pulmonary trunk. So this is the normal flow that flows. So, when the right ventricle contracts, it's going to force blood across the pulmonary valve into the pulmonary trunk. So that is this flow. And you can see it's a systolic flow, right? From the onset of the QRS LVT, it's a systolic flow, and it's below the baseline. You can also see this flow, which is above the baseline in diastole. And we spoke about this one. This is pulmonic insufficiency. It's above the baseline. So your Doppler is giving you a lot of information there again, systolic flow, normal flow across the pulmonary valve, and we trace, we plane the borders of the envelope, and it will give us the velocity, because velocity is on the vertical axis and time is on the horizontal axis. So we get a you plane the envelope, velocity is on the vertical axis and time is on the horizontal axis. So you can get information such as the peak gradient. Okay, you can get information such as the mean gradient. Um, all right, let's. Okay, so we put the color across the tricuspid valve, and you see you have this mosaic color right there, or varying shades of blue right there. So again, blue tells you that the flow is away from the transducer. Your transducer is right there. So this is a flow from the right ventricle across the tricuspid valve into the right atrium. So this is your TR, okay, short axis view at the level of the aorta. So this is the TR, this blue mosaic color. This is the TR right there, okay? So you locate it with the color, and now you can use your pulse wave and your continuous wave Doppler to do some quantitative assessment. Okay, so you put the cursor, the sample volume is right there. This is the sample volume, and you press P Doppler, and because it's not a significant tricuspid regurgitation, you don't get a well-formed envelope. So you don't get a well-formed envelope because it's not significant. Okay, so this is your short axis at the base of the heart. Remember, the base of the heart, you have the mitral valve. Okay, so it's the base of the heart. We don't want to see that. So we incorporate Doppler in all aspects of our echo studies because it had okay, so this is short axis at the level of the papillary muscles. Okay, this is the anterior lateral papillary muscle, the posterior medial papillary muscle. Okay. So this is short axis at the apex. Okay, so short axis at the apex. So this is our four-chamber view. So the cursor, the probe or the transducer is in the mid-clavicular line, fifth intercostal space, and the marker is about the 4 or 5 o'clock position. And you just adjust it. You want to get your heart standing straight up. So it's your LV cavity, lateral wall, the apex. This is your septum. This is your mitral valve. This is the anterior leaflet, posterior leaflet. This is the left atrium, pulmonary vein, atrial septum is right there. It's your right atrium, right ventricle. So again, we have to do some Doppler studies. All right, so you always, you should do color flow first to see if any significant pathology is there. So we'll put color across the mitral valve. Okay, so the color is across the mitral valve, and you're looking for regurgitation, of course. And we, regurgitation is a mosaic color. If the flow is moving away from the transducer, it's going to be varying shades of blue or a mixture. So we do the same thing across the tricuspid valve. So you put your sample is across the tricuspid valve or your sector, and you just turn your color flow on. And if you look closely, you can see your bluish color down here. Okay, so it's moving away from the transducer, which is right there. So it's a flow from the RV across the tricuspid valve into the right atrium. So it is tricuspid regurgitation, and it looks like this. So TR looks like this, bluish color. Okay, can you see it a little bit better right there? So this is the bluish color, which tell you that there is a flow from the RV across the tricuspid valve into the right atrium. It's moving away from the transducer, and it's blue. You do the same thing across the aortic valve. So this is the 5-chamber view. You, from the 4-chamber view position, you just pull the angle of the transducer downwards a little bit to open the aortic valve, and you put your color. You're looking for aortic insufficiency or any abnormal flow. Okay. So, all right, so that is still, so we're going to do our P doubler now. So the P doubler across the aortic valve, or the left ventricular flow tract. So that's the proper term for that, left ventricular flow tract. So, well, anyway, so our four chamber view, our cursor is across the mitral valve. The sample volume is at the tip of the mitral leaflets, and it's a P doubler assessment. Okay, so this is saying PRF, pulse repetitive frequency. So it's actually a P doubler assessment. PRF means pulse repetitive frequency. So it's actually a P doubler measurement. So you get a flow above the baseline. So the baseline is right there. So you get this repeated flow, a tall one, a short one, tall, short, tall, short, tall, short. Okay? So it's above the baseline, and it's telling you that you have a flow from the left atrium across the mitral valve into the left ventricle. It's moving towards the transducer, and it's above the baseline. So this is our E velocity and our A velocity. Remember that the E velocity is because the mitral valve open and blood is sort of sucked into the left ventricle from the left atrium. So you get an E velocity, and then your A velocity is when the atrium contracts. So you get a E velocity, A velocity, E velocity, A velocity. It's a diastolic flow from the end of the T wave to the QRS, and it's above the baseline. Okay? So that's your mitral inflow. It's a P doubler measurement. Okay, and then you put your color across the mitral valve, looking to see if there's any significant. There's probably just a very trace amount. So, but you have to put your P doubler and your C doubler there as well. See that there's a little bit, just a little. Okay, so that's mitral regurgitation, and then you put your P doubler or C doubler across there to identify. So the color flow is to just identify if any significant pathology is there, and then if you want to quantify what's going on, then you put your P doubler and C doubler. So the cursor is there, the sample volume is there. You turn on. This is still a P doubler. I mean, you can see a hint of something, but it's not significant. So once you don't get a complete envelope, it's not significant at all. Okay. So for chamber view, this is your cursor. The cursor crosses the pulmonary vein. Remember, we said there's one pulmonary vein right there, and there's another there. So it crosses the pulmonary vein. The sample volume is right there, and you just press P doubler. So this is a P doubler assessment, and you get there's a spectral envelope here. There's another spectral envelope there, and there's a spectral envelope there. So this, and that. So there's a systolic flow. So this is the systolic flow. So this is your systolic flow. Systole is from the onset of the QRS to the end of the T wave. So this is systolic flow. You also have a smaller diastolic flow. Diastole is from the end of the T wave to the QRS. So you have a smaller diastolic flow. And then you have what we call an atrial flow reversal. Atrial flow reversal. This envelope is below the baseline, is reversed. So in ventricular systole, you're going to have flow from the pulmonary vein into the left atrium. In ventricular diastole, you're also going to have flow from the pulmonary vein into the left atrium. But when the left atrium contracts, it's going to force blood backwards into the pulmonary vein. So it's going to be moving away from the transducer. Hence, your atrial flow reversal is below the baseline. So systolic component, diastolic component, atrial flow reversal. So you should be able to explain what's going on. Okay. So what's going on here? Okay. So this is our apical four-chamber view. This is the cursor, and the sample volume is right there. This is the mitral annulus. Mitral annulus. This is what we call, this is a tissue Doppler assessment. Tissue Doppler is a form of pulse wave Doppler. So when you put it on this location, there's a button to say tissue Doppler, TDI button, TDI. You press the TDI button, and you get an envelope above the baseline, and you get two envelopes below the baseline. So what's happening? The mitral annulus in systole, the mitral annulus moves upwards. So it moves towards the transducer. So you're going to get, this is what we call the S prime. S prime. It's the tissue now. We're looking at the movement of the tissue at the mitral annulus. In systole, it's going to move upwards. So we get an S prime. In diastole, the mitral annulus is going to move downwards. There are two diastolic components. You have an E prime and an A prime. So this is what we call tissue Doppler imaging. You're actually looking at the movement of the tissue at the mitral annular level. A systolic component, S prime, and two diastolic components, E prime and A prime. Tissue Doppler image. Okay, so you do the tissue Doppler imaging, the medial mitral annulus and also the lateral mitral annulus. Medial mitral annulus, lateral mitral annulus. You get the same thing though. You get an S prime because the annulus is going to move upwards in systole, S prime, and you also get two diastolic component, an E prime and an A prime. The difference between the medial and the lateral annulus is that the lateral E prime is usually larger than the medial E prime. The lateral E prime is usually larger than the medial E prime. So that's very significant. Okay, so you put color across the aortic valve. You're looking for aortic insufficiency. So again, the left ventricular flow tract, the sample volume, the cursor, the sample volume, and you get a systolic envelope, systolic envelope. So this is the left ventricular flow tract, and it's a PW measurement. Left ventricular flow tract assessment, PW measurement. And you should also, across the aortic valve, you should also get a CW measurement. So this is a continuous wave measurement. So again, you just, instead of pressing PW, you press CW, continuous wave Doppler, and you still get the same systolic envelope, and you just plane it. You can get the maximum velocity, you can get the maximum gradient, and you can get what we call TVI, time velocity integral. We'll go over that. Okay, so this is your significant TR. Well, not very significant, but there's TR. You can see the mosaic or the bluish color right there. It's a color. Okay. Well, this is not, I'm not going to, that's not a Doppler assessment, so I'm not going to go over. So again, Doppler help us to look at regurgitation, identify regurgitation, and then to quantify regurgitation. It also allows us to look to see if there is any shunt or any abnormal flow and to quantify that. It helps us to, if the patient have a stenotic valve, it also helps us to assess the stenotic valve, and we can give valve area, we can give a lot of stuff. So again, this is the two-chamber view, the inferior wall and the anterior wall, okay? So apical three-chamber view. So So you put the color. So apical three-chamber view, and you put your color across the aortic valve, and sub is across the mitral valve as well. And you're looking for regurgitation, so you have to look carefully on the color. So this is your subconscious view, and one of the important thing about the subconscious view, you want to do your hepatic vein flow. You want to do your Doppler assessment of the hepatic vein flow. That's very, very important. It should be a part. It should be a part of your routine study. So once you start doing your echoes, then hepatic vein flow is going to be important. And let's hope we have one here to show you. I mean, you're going to do your color as usual. You're going to do your color assessment of the different valves. So the good thing about the subcostal view, you have a good view of the ventricular septum and the atrial septum. So if there's a septal defect, you can put your color and identify. And you can also look at the other valves. So but your proper interpretation of Doppler is very, very important. So you have to be able to identify the Doppler, and you have to know what it means. So you need to fully understand Dopplers. So this is your inferior vena cava running through the liver. The hepatic vein is someplace right there. So this is the hepatic vein, and you want to Doppler that. That's exceedingly important for you to Doppler your hepatic vein, because it gives you a lot of information, and it can give you hemodynamic information as well. So you want to do pulse wave Doppler of the hepatic vein. Okay, so you put your this is the cursor, the sample volume is right there, and you get these. So remember your hepatic vein. This is the transducer. This is the hepatic vein, and the hepatic vein is draining into the inferior vena cava. I remember the inferior vena cava is going to drain into the right atrium. So your hepatic vein flow is actually moving away from the transducer. So you're going to get a systolic component, a diastolic component, and then an atrial flow reversal. Systolic component, diastolic component, atrial flow reversal. Systolic, diastolic, atrial flow. So identifying the hepatic vein flow and the different components is crucial. So you need to understand this. So hepatic vein flow. So that is, I mean, this is your first look at Doppler incorporated into the regular echo studies. We're gonna have to go over a few more, looking at some pathology that is significant regurgitation and stuff like that. So you'll have a much better understanding of the Doppler. So we